Hello. I'd like to welcome you to this afternoon's Institute of Health Studies Satellite Seminar. Joining me in the studio this afternoon is Dr. Heather Skirton, Nurse Consultant Genetics at Musgrove Park Hospital in Taunton, Somerset. I'd actually like Heather to say something about herself before I say any more. Heather.
Thanks, Faye. As Faye said, I'm the Nurse Consultant in Genetics at Musgrove Park, and in my work I cover the whole of Somerset. I've actually been working there for about 14 years now, first as a genetic nurse specialist and then as nurse consultant over the last 2 years. Before that I worked as a nurse and as a midwife for about 11 years before coming into genetics. The nurse consultant post has a strong educational component, so I actually work 3 days of work in clinical work and 2 days at the University of Wales College of Medicine teaching genetic counselling.
Thank you, Heather. We also have in the studio this afternoon Professor Alan Peterson from the Sociology Department here at the University of Plymouth. I'd also like Alan to say something about himself before we move on.
I'm Professor of Sociology, as was mentioned, and I've got a particular interest in the new genetics, and I've done quite a bit of work in the media portrayals of genetics in recent years. Before coming to Plymouth in mid-2001, I was in Perth, Western Australia, and I worked there at the Murdoch University. And in addition, I worked in the School of Nursing for some time at the Skirton University of Technology for about 4 years or so. So I've had a range of experience working in sociology departments and in the School of Nursing.
Thank you, Alan. In a little while, Heather will do her presentation to us on communications and how it affects families in relation to genetics. I'd like to provide some housekeeping information before she starts her presentation. At the end of her presentation, there will be an opportunity for her to take questions from you out there, and you can contact us in the studio on 01752 233 646. You can also contact us via email at tvstudio@plymouth.ac.uk. We'll be happy to receive emails at any point during Heather's presentation, and we'll pick them up after she's done her presentation, and she'll make a response to them then. I look forward to hearing from you in the course of the afternoon. And I'd like to invite Heather to do her presentation at this point. Over to you, Heather.
Thank you, Faye. This afternoon I want to talk about communication with families and to go into some depth about the ways in which communication works in genetic counselling, and then at the end of my talk to extrapolate that a little to look at how these same themes can be used in nursing and midwifery generally. Now, when I tell people that I work in genetic counselling, usually they're quite thrown by that. Many people these days are familiar with the term genetic counselling, but they don't really know what is involved in the process of genetic counselling. If you press people, often they'll talk about science, and they have an image of someone in a white coat with a test tube in the lab. And indeed, when we're asked to give interviews for television, often the interviewer will ask us to actually go into a lab and put a white coat on for the purpose, which we avoid if possible. Many other people link genetic counselling purely with giving people reproductive options, so they think it only applies to pregnancy. And then there's another group of people for whom genetic counselling is probably linked with eugenics because of the history of the eugenic movement, the way that genetics developed really as a science out of the study of eugenics, and because of the links with the influence of eugenics, particularly during the Second World War, that's very prominent in people's minds in this country. And while all of these three aspects, reproduction, science and eugenics, are linked with genetic counselling, they are by no means any part of the whole story. And if we look at a well-recognised definition of genetic counselling, we find that it's principally a communication process. But the next part of the definition is the important one. It's always connected with human concerns. So when people think about genetics in connection with Dolly or GM foods, that has no part to play in actual genetic counselling. It involves information giving, discussion of risks and options, and very importantly for genetic counsellors, the support that's offered to families during the process. Now, I've said that genetic counselling is principally a communication process. And when I went to the dictionary to look at the origins of the word communication, I found it came from two Latin words, cum meaning together with, and unio, which means union. So really communication is a word that describes a uniting together, and in this case a uniting together of people. It involves usually the use of signs and symbols, whether verbal or written or pictorial. It always conveys meaning, and good communication or even poor communication usually affects a change. If we look at that even more deeply, we find that communication should result in shared meanings between the two people involved, or the more than two people involved. And as a result of changing shared meanings, it reduces uncertainty. Now, in many cases where communication occurs, some aspects are made more certain. So it does have the effect of reducing uncertainty. But in good communication, I think of one feature is that often new areas of uncertainty will emerge as a result of that communication. So although it reduces uncertainty in certain ways, it may also produce other areas of uncertainty. And it usually changes the relationship of the people involved. Now, my particular area of interest as a genetic counsellor or genetic nurse specialist, you can use the terms interchangeably, was how this process of genetic counselling, the communication between myself and the people in front of me in a genetic counselling session, how that communication altered their lives. I was really interested in what the outcomes were for those people, those clients. And when I went to the literature, I was not satisfied with what I found. By the time I was thinking about this in some depth, I had quite a lot of experience. And the literature really related to outcomes in two main areas. One outcome was what you'd term educational, really. Did people's knowledge of their risk change after they'd had genetic counselling? So presumably they were coming to talk about a genetic condition. Did they go away knowing more about the risk that they themselves or members of their family or future children would develop the condition? The other area where people had studied outcomes was in terms of reproduction. And some studies looked at the outcome in terms of if someone went for genetic counselling, did that change their reproductive plans or indeed their reproductive behaviour? So you had studies where people were measuring how many children were born after counselling as opposed to in families where no counselling had occurred. And from my experience, I knew that those sorts of measures just didn't go anywhere near telling the whole story. For a start, many clients come for genetic counselling who have already completed reproduction or have no reproductive intention anyway, because unbeknownst to many people, genetic conditions affect people right up into the elderly age group, and so many people who come to see us are actually adults or even, you know, over 40s, 50s or 60s. They're not thinking about reproduction. I also knew that when people were making decisions, the actual risk figure didn't seem to make all that much difference to them. It was really the burden of the risk that seemed to make the difference. So, as part of my own PhD studies, I decided to look at outcomes from the client's perspective, and it was from that perspective that the area hadn't been studied before. So I used grounded theory methodology to do this study. It's a qualitative method, and I studied 43 families longitudinally. So I first met the families when they were referred to the genetic service. I saw them again after they'd had their genetic counselling sessions, and I went back about 6 months later and talked to them a third time. Now, grounded theory studies involve looking at major themes and then using those themes to create a theory, and in this case the theory was about the outcome of genetic counselling. And there were 4 main themes that emerged that I want to discuss with you today. The first major theme was one that I've called lay knowledge, and other researchers like Martin Richards from Cambridge have used this term lay knowledge or lay beliefs. And it refers to the sort of knowledge or belief that a family has about a particular condition that they have developed to explain how that condition has occurred in their family. And when I first went to see the families, before they'd had any contact at all with the genetic service, I asked them why they thought the condition had occurred in their families. And everyone had some sort of a theory, some hypothesis. Now, in families where the condition had been known for a long time, for example, a family where Huntington's disease had been diagnosed maybe 2 generations before, people had a very, very well developed hypothesis. In families where it was a completely new diagnosis, for example, if a couple had a child with a chromosome abnormality that was the first of its kind in the family, then they seemed to use other information that they had that they thought might be related. For example, they knew about diet in pregnancy, so they would relate that to explain what had happened during the pregnancy with regard to the genetic condition. And I just want to give you a few quotes from some of the patients that I spoke to with regard to their lay knowledge. Linda had a child with cerebral palsy, or so she'd been told. The little girl was developmentally delayed physically, but she didn't seem to be learning cognitively in the way that Linda would have expected. She repeatedly went to the paediatrician and was told, yes, this was cerebral palsy, but she said to me that she was very relieved to have the genetic referral because she knew that it was something inherited. She said, you know it's something else, and you've got this weird feeling, you know, this feeling that's constantly nagging at you. Another woman had a referral because she had a family history of breast cancer, and she felt that she was absolutely certain to develop breast cancer herself. She said, my sister had it and I just thought, it's in the family, it's bound to get me. Another mother I spoke to had a baby who'd been diagnosed with partial Down syndrome. The baby was very young and had no evidence of learning delay at this stage, but the baby did have some unusual creases across his hands, and he actually had webbed fingers. The mother took this to be the focus of the genetic condition in the family. She was not really worried about his development, but she was worried about this abnormality of his hands. Now, the paediatrician and a genetic consultant had by this time spoken to this mother and explained that the baby had unusual chromosome pattern. And I said to her, "What concerns you most?" And she said, "His hands." And I said, "Well, why do you think he has these unusual hands?" She went through a whole list of things that she considered could be the possible causes. One was that she'd used a video display unit during her pregnancy at work, and maybe the rays had come out and affected the baby while it was in the uterus. Another possible explanation was she'd used ringworm cream. Then she said her husband had used weed killer when she was about 7 months pregnant, and maybe that had altered the baby's hands. And then lastly, she talked about diet in pregnancy and said she knew that her midwife had told her all about drinking plenty of milk, and perhaps she just hadn't drunk enough, and that's why the baby had these problems. Importantly, when I went back after families had had their genetic counselling, they usually felt that their own previous experience, the family's experience, was far more relevant than the scientific explanation that they'd been given, unless the scientific explanation had been given against the background of the family's experience. And what I learned from this was it's very important for us to ask families about why they think something has happened, and to then use that information that they have about their own family to help them understand the scientific explanation. And where that didn't happen, families simply reverted to their lay knowledge, and they weren't benefiting at all from the information that they'd been given at the genetic counselling session. The second major theme was certainty, or need for certainty. Webster and Kruglansky are two authors who've written about the need for certainty as an individual trait that we each have, and to some degree we either need certainty or have a very low need for certainty in our lives. And this obviously does alter a little according to the situation, but it's a general trend, and it may be interesting later for you to think about your own need for certainty. Genetic counselling isn't an essential service. People can either opt in or opt out. And what I found was the clients who allowed themselves to be referred or requested referral had a high need for certainty. They wanted to know what was going to happen, and they used the genetic counselling referral to try and help them to understand what the future might be by giving them more certainty about the present. I don't think this is true of all patients who use the health service, and obviously when we're working with patients we need to assess whether their need for certainty is high or not. One of the patients said to me about her little girl who was aged 4 at this time and was having some serious learning problems. I'd like to be in control of what's going to happen. If there's anything that could be done and you didn't do it, you'd end up kicking yourself. Other people said, I'd rather know what's coming. Another woman, I like to know everything, absolutely everything. And another woman whose little boy was affected with a genetic condition said, as long as they can give me a name, I'll be all right. I can say, right, let's get on with our lives and worry about it as it comes. But all this not knowing, God, it's just awful. for that woman and her husband, the strain of not knowing what had caused the problem with their little boy was absolutely enormous, and they spent a lot of time telling me how it had actually affected their whole lives. She said that she could never put it out of her mind, just the not knowing. So one of the services provided by genetic counselling is actually giving people more certainty. And of course we don't always make a diagnosis, but even in those families where a definite diagnosis was not made, the people said at the end of the study, they said, at least I feel in my own mind that I've covered all the territory. I'm certain there's nothing more I can find out at the moment because science just isn't there yet, and that had given them some satisfaction. The third major theme was relationship, and it almost goes without saying that the relationship between the genetic service and the individual patient was of importance. But actually what came across very strongly was that people needed to feel they were treated as an individual. They wanted to know that the information they were being given was tailored to their exact circumstances, and they wanted to know that the staff were interested in them. Counselling skills were important. People felt that the people dealing with them, they wanted them to be sensitive to their issues. And one woman said, I think talking to the nurse has been helpful because friends try to reassure me, but you just can't wipe away what has happened. Other people don't actually want to listen and hear my misery, but she listened and she didn't tell me not to worry. Another woman who was telling the story of the loss of her baby said, I did find it very hard. I think counselling skills are essential. I remember feeling I want to cry. I was sitting there in the garden on a sunny day just telling this story, and it was so painful. It didn't need to be very profound, the sort of expression of individuality on the part of the staff. I remember one woman said that the genetic nurse had remembered a little boy had fallen over the last time they'd seen each other, and she asked about him, and that was enough to make her feel, oh, this person really remembers me and I matter. Altogether, these three things, need for certainty, lay knowledge and relationship, come together to form really a total outcome which really is related to psychological adaptation. But for people to be able to adapt psychologically to their situation, they need to be able to integrate the lay and the scientific knowledge that they've been given and that they've developed through their lifetime. They need to have uncertainty reduced in some way, even if it's just that they've pursued every avenue open to them and the staff have done the same. And they need to know that positive relationships have developed because they've been valued as an individual. So communication in the context of genetic counselling really does result in shared meanings between the clients and the counsellor, shared meaning of what it is to have a genetic condition, of how that affects someone's life, and of what the future might hold. It reduces uncertainty about the future by giving people more control, and it actually changes their relationships. Now, I said that the overall outcome of genetic counselling when there's effective communication is that people adapt psychologically to their situation, and that doesn't just relate to genetic counselling, it's integral to all healthcare settings. And I'd just like to give a few examples of how the findings of this study and genetic counselling in general might relate to clinical practice in a number of other areas of nursing and midwifery. To start with midwifery, and for this I think that the example I'm going to use relates to the use of lay knowledge. I was thinking about a family where the mother in the family is a heavy smoker, and the midwife is talking to that mother about the effects of smoking on the fetus. If that mother comes from a family where perhaps she or her sister or mother have been smokers and they have had children who perhaps have been born between 7 and 8 pounds, then that information is going to be have far more impact on that woman than any statistics about the effects of smoking on the fetus. And so the midwife can use that information about the impact, the power of lay knowledge within the family, to perhaps open up discussion about that and use that to give the woman information and to support her in perhaps reducing her smoking. In paediatrics, the example I've thought of is in terms of the need for certainty. Parents who come onto the ward and who have a child who is obviously seriously ill, perhaps with a possible potential diagnosis of leukemia, for example, may have a powerful need for certainty. In my study, it was quite, in some ways, encouraging to know that when we give bad news to people in this situation, they would actually prefer certainty to uncertainty. So in genetics, even the people who'd received bad news said, but I'd much rather know. It's easier for me to adapt if I know for sure. And we can perhaps use this in context of giving bad news to others in our practice. In mental health, I think it's self-evident that the relationship is of vital importance in delivering health care, and the relationship between a client and a CPN, for example, could be absolutely crucial in the health and prevention of further crises for a patient. And in the surgical context, many families with a family history of cancer regard themselves as being doomed, of having there's an inevitability about the cancer diagnoses in these families, and they may regard themselves as being certain to develop cancer in the future, and that may actually have an impact on their presentation for screening. And knowing that may help a nurse working in this setting to address those issues with the family. Finally, I'm using this slide really to remind me that it is essential that to work competently, we have to be involved in reflective practice. Communication between clients and ourselves is an integral part of reflective practice. But to reflect well, we need to be communicating with our colleagues and peers and discussing cases, looking back over our work and planning work for the future in a way that's very open. We also need to have an internal dialogue with ourselves, to be our own internal supervisors, to communicate internally about our practice and to be reflecting back on that as long as we work professionally. And so I think communication really is the core and the foundation of all working practice in both nursing and midwifery settings. Thank you.
Thank you, Heather. Whilst you come and make yourself comfortable with us back on the sofa, I will share two of the questions that have already come through for you, an email. We've had an email through from Plymouth, and they have asked, you talked about a woman who had a hypothesis about her web-fingered child, which included, example, her partner using weed killer, and she having used a visual display. How could these hypotheses be used within the counselling? If, for example, you need to try and say that there is no evidence that those things will have influenced the outcome.
It's a very good question. I think partly what I'm trying to say about the lay hypothesis or the lay beliefs is that they can't be addressed at all if we don't ask about them. And so I think the first step in addressing that is to actually have that in the open. If I hadn't asked the direct question, I wouldn't have known what that woman was actually thinking. So I think partly addressing it involves just asking the question, opening out, what do you think may have caused this? And then you can start to talk about it. But I think to take that further, once I knew that those issues were there for that woman, it did enable me to sort of go back to first principles and talk to her about how the baby had developed from conception, and the fact that the baby's hands had been developing for a very long time before she was using the VDU or the weed killer, and to open out that discussion, to ask her when she thought this might have happened, to ask her what she thought about the development of the baby, and to weave in those different aspects. And actually often people rationally know some things, and so she did actually know that probably the use of the weed killer at 7 months pregnancy was too late for this to have been affected. But it needed discussion to be able to bring that out, and for her to actually start to integrate that knowledge too. And I don't think it's an easy thing sometimes, but what I suppose I'm trying to say is it's not enough just to tell people that hasn't occurred. It has to be a discussion with someone, real communication with them, and it may take more than one discussion. It may take many discussions. Some people may never come to the point where they don't think those things, but I think it's our responsibility to start the discussion and to give them the opportunity to say what they think, and even just enabling them to say what they think may actually be quite, in a sense, therapeutic to them as well.
Yeah. Alan, is there anything you want to add to that or develop from what Heather's just said there?
One point I want to ask you, Heather, is to do with this notion of non-directiveness. It's one of the ideals of counselling, genetic counselling, runs through all the literature and it has through its modern history. In the clinical setting, when someone comes in and they want information from you, as they might expect, they want some advice on how to act on the information that you give them, how do you negotiate that situation of being non-directive and yet allowing them to have their concerns addressed when they want information, concrete information to go away with?
Well, non-directiveness is a topic that's bantered around a lot in genetics, as you've said, and I think that it's misused sometimes. What we understand by non-directiveness is really a complete lack of coercion. So there's no room for any sort of coercion in genetic counselling. But I think non-directiveness, you could replace that term by saying, in a way, shared decision making, because it's very poor practice to say to someone, I will give you the facts and you decide it's not for me to comment. That's not the role of a genetic counsellor at all, the role of any healthcare professional, I don't think. It's more to give the information and then in a skilled way enable the person to uncover, to explore what options they might wish to take, and to give the information that would enable them to explore those options properly. And I guess that many experienced genetic counsellors would say that when a person comes and sits down in front of them and clearly has a route planned, clearly has an option planned, or would find some options unacceptable, that we wouldn't present all the information in a completely neutral way, but we may go some way to affirming that may be the best option for you. And a good example would be if a couple came in for genetic counselling and they had a risk of a genetic condition in the family, they were already pregnant. And they clearly stated near the start of the discussion that because of their religious faith they would never consider termination of pregnancy. I think it would be very unsubtle and unskilled to then present the options and say, you decide. I would be far more likely in that situation to say, you know, there are tests we can do, but from what you've said to me, that wouldn't be acceptable for you, and therefore the route you've chosen this, and I think in your circumstances that's very reasonable. So in a way supporting them through that. People often say, what do other people do in these circumstances? And again, I think that I would always say, try and give both sides of the coin, but say some people choose this route, other people choose that route, and I wonder which seems more appropriate for you. Genetic counsellors do need to be trained in counselling skills to be able to, you know, both support people and to help them explore the options that are appropriate for them. So I think non-directiveness is a good term if you take it to mean lack of any coercion. And of course non-directiveness, that term, came out of a response, a reaction to any eugenic claims by other people that genetics was eugenic. And I suppose in some way, if you think about public health genetics, there are aspects of eugenics there, just like there are in most public health situations, really. But that's very much, public health concerns a population. Clinical genetics and genetic counselling is only concerned with the individual family, not what's best for the population as a whole.
I find some of what you say scary, because I think whilst it provides an insight, the use of lay knowledge and how as health professionals we can improve our communication with families, I think for me I would lack some confidence once someone is opened up where perhaps they're coming from. And if I went back to the question that came in from Plymouth, how do you use the hypothesis that the family have got to inform them in a scientific way of what's going on? I think for most of us we will get scared at that point as to what comes back, that we may not have that expertise to take it any further. And it's perhaps looking at the sense of how do we close sensitively as we refer that person on to someone like yourself or the genetic services to take the discussion on further. I listened to you and your presentation, and some of what you said, I thought we would perhaps pride ourselves as healthcare providers that we communicate well and think we communicate well. But I'm left feeling totally unsure, and that unsure is because of lack of knowledge, expertise, and uncertainty of the area we're going to walk into once we open perhaps a can of worms.
Well, I think that's quite reasonable, that fear really, because if you open a can of worms, you know, you're left with them. I think it's, in some way, if our health professionals don't feel that they can communicate very well, that's in some way reassuring, because at least they're aware that it is a skill. And I think many people in the past have thought, oh, people like to talk to me, I'm a good communicator, I don't need training. But actually, communication skills and counselling skills are learnt. They're not natural. People may have good personality. And if nurses and midwives feel that, I think that's extremely positive, because they're not going to cause any damage if they're sensitive to that.
Thanks.
I mean,
I'm banking questions.
Okay.
I'm going to take a telephone call now from Margaret Fisher in Exeter, and I'm going to go through a series I've got developing on the screen as well. Okay. Margaret, over to you.
Hello, Helen. Thank you very much for your talk. Sorry, I just need to turn this down. I'm joined by Maggie Doman, child lecturer, and a group of 9 midwifery students here. They arranged amongst themselves that half would come out of their teaching session and half would stay in. So I think the students here have enjoyed your talk.
Thank you.
In view of the fact of you having done the longitudinal study, I want to just build on the question that Plymouth asked you earlier, because obviously we were able to follow up these women, and thinking back to your Down syndrome lady, did you actually find that lay knowledge versus scientific knowledge did have an ultimate influence on the acceptance of the condition? That if people had a really strong conviction that they'd done something wrong or whatever, like your particular lady, that she actually took longer to accept the condition, whereas those who perhaps just accepted the scientific explanation were better able to accept the condition? I'd be interested to hear what the findings were.
I don't think there was a direct correlation between acceptance of the condition and, well, hold on. Are you asking me acceptance of the condition or acceptance of the child with the condition?
Margaret, are you still...
Perhaps more so acceptance of the child.
Acceptance of the child, right. There didn't seem to be a correlation between the acceptance of the child, and this was, you know, one family of many who had a child with a serious genetic condition, and I didn't feel that it interfered with their acceptance of the child, but it did cause them a lot of psychological harm, this constant wondering. And as you have highlighted, and I didn't actually say, but you've pinpointed something that was very powerful, is the feelings of guilt and self-blame about the reasons for this child having problems. And I think that's what's helped. If we can help people to integrate the lay and scientific knowledge, that they can let themselves off the hook to some extent for the reasons that their child is like it. In another family, the family had been of the opinion that the baby's very abnormal birth was to blame for the baby's slowness, and the father had been castigating himself for the 18 months since that baby was born for not being more powerful in the delivery room and not insisting that the mother have a cesarean when he felt uncertain about what was going on actually at the time of delivery. And the fact that the baby had a genetic condition, and the genetic condition was diagnosed, was so powerful in letting him off the hook. He said that he, for the first time, had been able to relax. It was terrible that it was genetic, but at least it hadn't been his fault. His intervention wouldn't have made any difference, and that was a real release and marked a real change for that family in the way that they could deal with their son's condition.
Margaret, does that answer your question?
Yes, thank you very much. That was interesting.
Okay. Heather, Lynn Nichols has come through from Taunton with an email, and she's with a group of student midwives and all the lecturers on the Taunton site. And they've said they're interested to know if you found the media, either through factual documentaries or through fictional programs such as EastEnders, had any effect on people's lay beliefs or concepts of genetic problems.
Oh, absolutely. Some of you may have seen a series of programs recently called Bitter Inheritance on the BBC, and many patients have cited that as giving them more insight into genetic conditions that they may have had themselves, and it was a particularly good series for that and showed family stories. But when there are other examples on programs or radio, for example, I'm an Archer's addict, and some time ago Ruth had breast cancer, and there was a lot of discussion at that point about familial breast cancer, and we found that people were talking to us about that and actually hearing it in another form that they respected or enjoyed did actually help them to develop different sorts of, or to alter their hypotheses about things. So yes, it's a really good question, and really one of the things that we try and do is push these topics in the media more. And I think the fictional programs are actually even more powerful than the documentaries.
Great. I've got questions piling up on the screen, Heather. From Ray in Plymouth. Did you find that the psychological adaptation differed according to the differing conditions or the severity of the conditions of the clients that were in your study?
No. The psychological adaptation, and most people put this across as I've got more peace of mind. The number of people out of the 43 families who said it's given me peace of mind or it's put my mind at rest at the end of the study, referring to having gone through that process of genetic counselling, was overwhelming. And it didn't seem to matter whether these were what we would consider quite minor problems or major disruptions to life, like family condition of Huntington's disease or whatever. You couldn't measure any differences. But I will say that that's when we're thinking about minor or major, that's only my subjective assessment of that. And for the family, perhaps there isn't that degree of difference, because whatever's happening in your life is major to you. And so I think for us to make those judgments is quite difficult, but we do make the judgments subjectively.
I think that's useful for us to remember. Back to the questions. Plymouth. In referring to, you referred to couples or people saying, what do other people do? And the question that's being asked here, is there a possible use of frequently asked questions and answers as appear on some health websites? Do genetic counsellors make use of such published sources?
We do sometimes, and we would always refer people to very good sources of information on the internet. We tend to sort of vet them beforehand, because sometimes they can't be that helpful. Some things aren't helpful. But we do tend to use that a lot and refer people to other pieces of literature and things like that. The lay support groups are usually a fantastic source of very reliable literature, and we would always refer people to those. And some people do find it very helpful to talk to people in lay support groups about what they've done. Other people don't find that helpful. We don't have that sort of information that we generate ourselves, and I guess it's because we want to regard each couple or each family as very individual, and so we're not pushing them along the road of what other people often do. But if we're asked, we would use those, and we would always want to present both sides too, so some people have a genetic test for this, other people find it's easier to live with it if they don't know for certain what's going to happen, that sort of thing,
Okay. I've got a question on the screen from a student midwife in Taunton, Lisa Bond. She said she's interested to know whether you feel you're often left to pick up the pieces as a result of midwives' poor communication and or our inability to cope once the can of worms is open. And then there's a second part: should structured taught counselling sessions become a vital part of training?
To the second question, absolutely no doubt.
Okay.
I just feel that all health professionals should have at least some basic counselling training, but midwives and other people who are dealing with crises from time to time especially. In answer to the first question, when I started as a genetic nurse specialist about 14 or 15 years ago, quite a lot of the work we were doing was picking up the pieces, but that has changed dramatically, and I think that midwives are now usually very good at supporting people and in referring them on when necessary. So I think those two things have really helped patients enormously. We get the occasional case where you do feel you're doing a bit of crisis management work, but I'm sure that midwives would say the same about us because none of us ever gets it right all the time, and so I'm not trying to put forward the view that genetic counsellors always do it well. We don't, and hopefully if we're working very closely with our colleagues that that that's known, and families don't fall through the net, that someone picks that up, you know.
Okay. A question about your research methods from Plymouth.
Yeah.
Could you tell us a bit about how you chose your sample? Did you use theoretical sampling? And if so, could you tell us how this developed? And there are more subparts to it. So it's starting with, could you tell us about how you choose your sample?
Okay. Because this work on outcomes from the client's perspective had never been done before, I felt it was very important to try and look at the whole range of people who might come for genetic counselling. And so the sampling method I used was that I simply invited everyone who was referred for genetic counselling over about a 6-month period to be involved in the study. The only exclusion criteria were that they hadn't been seen in the genetic service before, because they would have had prior knowledge of the things I was asking them about. And if people were having a particularly difficult emotional time, like they'd just lost a child the week before or whatever, I didn't approach them. But apart from that, my sample was anyone who was referred to the genetic service during that period of time, and that was any condition and anyone over the age of 18.
Okay, a subpart to that, were many of your subjects individual, or were they families through couples?
Well, some of the people who were referred, of course, are children, and in that case the subjects were the parents of those children. So I actually interviewed, out of 43 families, 53 people, so there were 10 couples, and the rest were either the single parent who had chosen to be involved. I sent letters to both the parents of a child, but often it was only the mother who responded, and the majority of people in the sample were women, but that's very typical of genetic counselling as a whole, that most of our patients are female.
Okay. We've got Ray on the phone from Plymouth. Ray, can we hear your question?
Hi, Heather. It's been really interesting. Just go back to the lay beliefs bit. There was a medical anthropologist I knew called Charlie Davidson, who did some work about lay beliefs, and he had this, he came up with this plan, with this way of describing things as Uncle Norman, and the last person I met. Uncle Norman was the man who smoked cigars until he was 85 before he died, and the last person I met was a sort of 35-year-old who died of breast cancer. How do you deal with those sort of issues, which presumably come up all the time in genetic counselling? How do you deal with these lay beliefs? How do you say, well, there's no evidence for them, or there is, or what do you do? Thank you.
Okay, I mean, I think, as I said before, it's sort of opening them up and hearing about them, and then I think there is, if you have a good relationship with the client, then you are able to gently challenge these things, and I think, it's because it is essentially a process of communication about it, and it may take some time to address. So I suppose if someone says to me, I'm bound to get breast cancer because my mother had it when she was 52, then, I mean, sometimes I do use actually written material, but I will go back to basics and explain the sort of issues of somatic mutations as versus an inherited mutation, not in those terms, in lay terms, but go through what actually happens when someone gets cancer at that age, and always acknowledging that the psychological power of losing your mother when she was 52 of breast cancer is enormous, but the actual health risk from that is in essence very, very low. And I think it is, for me, a combination of dribbling in the scientific information, but always acknowledging the psychological content of what's there in the conversation that seems to work in the long run. And there will always be some people, of course, whose only way of coping is to believe that Uncle Albert, who smoked all his life, didn't die till 85, and that's their coping mechanism. And I think when you're trained in counselling skills, that's always at the back of your mind as well, that if someone's relying on that to keep going and keep existing, then you don't destroy that intentionally. In any case, people's defence mechanisms are so powerful that they probably will just hold you back if you try. So I think it's a process rather than a single mechanism.
Thank you. Alan, looking at the clock, we've got just under 5 minutes perhaps before this session ends. Is there anything else you'd like to say to Heather or ask about what she said?
Well, there are many questions actually. From the sociology point of view, I guess there are many problematic aspects about counselling that we could explore, and there's quite a rich literature around that. Some of it's to do with issues of certainty, and you mentioned certainty, people wanting certainty, and there's a debate in sociology as to whether you can ever have certainty. People come along, they're wanting certain quantum of information, and they look to scientists often. Scientists themselves can't agree, there's a lot of dispute going on. There's a debate going on about the value of direct-to-consumer genetic testing at the moment, and about the ethics of that, and there's been a number of published reports and newspaper articles about the value of that sort of testing. We're going to see more and more of these sorts of tests available in the future. And the people that come to you, they may have been looking on the web beforehand, they get their information from diverse sources. How do you stand outside that context? I mean, you've got a job to do, and people that you see might have a particular genetic condition, perhaps a single genetic condition, a monogenetic condition, rather than something that's more complex. Perhaps there might be environmental factors involved as well. I find it quite a challenging context when I look at it from a clinical perspective, because I mean that's the broader environment you operate in, and we're all expected to become more consumeristic in our orientation to healthcare. We're expected to go out and look after ourselves more and more, and to use these tests as they're available. I'm just sort of a general comment, I guess, but I can see all sorts of complexities that are starting to emerge, which make it very difficult to translate some of the new genetic technologies into clinical practice.
Heather, what I'd like to suggest is that perhaps we acknowledge what Alan has just said and leave it as a wide question that everybody ponders on over there. And as we make our way back to the university in a little while, we continue our discussion. I'm being told that I've got just under 2 minutes left. So it's really taking this opportunity to start to pull this together and encourage wider debate out there from the audience around the subject. I found it quite interesting. I could see Alan sitting there thinking, I'd like to get in, and I think it's a debate that could perhaps go on for hours. And I'd like, rather than putting a closure on it myself, to say to people out there, and those of you on the campuses listening to this, to please continue the debate. Heather is accessible to us, and I'm sure if emails continue to come in, she will take them.
Yes, absolutely.
Final word?
I think Alan's comment is really informing my final word, which is, I've talked about genetic counselling in a specialist context. Genetics is already, but to a greater extent, going to affect every aspect of nursing and midwifery care in the future as we develop more understanding of the basis of disease, all health, and pharmacogenetics and that and tests, as Alan says. So it's the business of every nurse and every midwife.
Thank you. Perfectly timed. Thank you. I'd like to thank those of you out there who've listened to this. See you at our next IHS Satellite Seminar. Goodbye.
Goodbye.
Hello. I'd like to welcome you to this afternoon's Institute of Health Studies Satellite Seminar. Joining me in the studio this afternoon is Dr. Heather Skirton, Nurse Consultant Genetics at Musgrove Park Hospital in Taunton, Somerset. I'd actually like Heather to say something about herself before I say any more. Heather.
Thanks, Faye. As Faye said, I'm the Nurse Consultant in Genetics at Musgrove Park, and in my work I cover the whole of Somerset. I've actually been working there for about 14 years now, first as a genetic nurse specialist and then as nurse consultant over the last 2 years. Before that I worked as a nurse and as a midwife for about 11 years before coming into genetics. The nurse consultant post has a strong educational component, so I actually work 3 days of work
to take questions from you out there, and you can contact us in the studio on 01752 233 646. You can also contact us via email at tvstudio@plymouth.ac.uk. We'll be happy to receive emails at any point during Heather's presentation, and we'll pick them up after she's done her presentation and she'll make a response to them then. I look forward to hearing from you in the course of the afternoon. And I'd like to invite Heather to do her presentation at this point. Over to you, Heather.
Thank you, Faye. This afternoon I want to talk about communication with families and to go into some depth about the ways in which communication works in genetic counselling, and then at the end of my talk to extrapolate that a little to look at how these same themes can be used in nursing and midwifery generally. Now, when I tell people that I work in genetic counselling, usually they're quite thrown by that. Many people these days are familiar with the term genetic counselling, but they don't really know what is involved in the process of genetic counselling. If you press people, often they'll talk about science, and they have an image of someone in a white coat with a test tube in the lab. And indeed, when we're asked to give interviews for television, often the interviewer will ask us to actually go into a lab and put a white coat on for the purpose, which we avoid if possible. Many other people link genetic counselling purely with giving people reproductive options, so they think it only applies to pregnancy. And then there's another group of people for whom genetic counselling is probably linked with eugenics because of the history of the eugenic movement, the way that genetics developed really as a science out of the study of eugenics, and because of the links with the influence of eugenics, particularly during the Second World War, that's very prominent in people's minds in this country. And while all of these three aspects, reproduction, science and eugenics, are linked with genetic counselling, they are by no means in clinical work, and 2 days at the University of Wales College of Medicine teaching genetic counselling.
Thank you, Heather. We also have in the studio this afternoon Professor Alan Peterson from the Sociology Department here at the University of Plymouth. I'd also like Alan to say something about himself before we move on.
Sure. I'm Professor of Sociology, as was mentioned, and I've got a particular interest in the new genetics, and I've done quite a bit of work in the media portrayals of genetics in recent years. Before coming to Plymouth in mid-2001, I was in Perth, Western Australia, and I worked there at the Murdoch University. And in addition, I worked in the School of Nursing for some time at the Skirton University of Technology for about 4 years or so. So I've had a range of experience working in sociology departments and in the School of Nursing.
Thank you, Alan. In a little while, Heather will do her presentation to us on communications and how it affects families in relation to genetics. I'd like to provide some housekeeping information before she starts her presentation. At the end of her presentation, there will be an opportunity for her
any part of the whole story. And if we look at a well-recognised definition of genetic counselling, we find that it's principally a communication process. But the next part of the definition is the important one. It's always connected with human concerns. So when people think about genetics in connection with Dolly or GM foods, that has no part to play in actual genetic counselling. It involves information giving, discussion of risks and options, and very importantly for genetic counsellors, the support that's offered to families during the process. Now, I've said that genetic counselling is principally a communication process. And when I went to the dictionary to look at the origins of the word communication, I found it came from two Latin words, cum meaning together with, and unio, which means union. So really, communication is a word that describes a uniting together, and in this case, a uniting together of people. It involves usually the use of signs and symbols, whether verbal or